Dear ladies and gentlemen, first, may I thank for the organizing committee to give me this chance, and it's a great pleasure for me to be able to attend this grand conference and present this topic with gratitude, revisiting the oxygen delivery and consumption. I have nothing to disclose for this lecture. Now, we take a look at what we know already about oxygen delivery and consumption. Oxygen delivery is the amount of oxygen that the body provides to the peripheral tissue per unit through the circulatory system. That is, the rate of arterial oxygen delivery is the product of cardiac output and arterial oxygen content. Oxygen consumption is the tissue oxygen uptake per unit time. The basic condition for maintaining the normal function of the body is the balance of oxygen delivery and consumption. According to this formula, this balance is related to cardiac index, hemoglobin level, and pulmonary function, which is the main factor of arterial oxygen saturation and alveolar oxygen partial pressure. But how do we relate this knowledge into clinical practice? Here comes a question. When do we need to rebalance oxygen delivery and consumption? The answer is the balance is broken. That is, oxygen delivery decreased or oxygen consumption increased. And how can we rebalance oxygen delivery and consumption? Let's come back to the factors involving this balance. We can improve cardiac function to increase cardiac index or cardiac output. We can transfuse blood to increase hemoglobin level, or we can improve pulmonary function or treat original diseases such as fever or sepsis to normalize metabolism so as to decrease oxygen consumption. During operation, the most common situation where anesthesiologists met of the disturbance of oxygen delivery and consumption is blood loss. So we need a practical strategy for red cells transfusion. Current transfusion guidelines in different countries or areas all suggest restrictive strategy is that red cells are usually not required when hemoglobin level is not less than 10 grams per deciliter, and usually required when this level is less than 7 in China and Europe and 6 grams per deciliter in the United States. However, what about the patient with HbA level between 6 or 7 to 10 grams per deciliter? What's the transfusion trigger and what's the target of HbA level? That means if the patient has a level of 7 to 10, we could transfuse him or not. For both choices, we follow the guidelines, but we make different medical decisions. Why? Indeed, all guidelines tell us we need to make a decision based on patient's condition and a physician's own experiences. But these guidelines do not tell us how to objectively evaluate a patient's condition. So we have to make different subjective decisions based on our own experiences. Moreover, the restrictive strategy is hemoglobin level based, and the transfusion trigger is mainly dependent on HbA level. So, no transfusion target is pointed, it still remains close in red cell transfusion. And this means we need another practical transfusion guidelines or strategy, individualized red cell transfusion strategy. Here comes another question. How to make red cell transfusion individualized? We revisit oxygen delivery and consumption into it. The main function of red cells is carrying oxygen so as to maintain the balance of oxygen delivery and consumption. As we know, this balance is directly proportional to hemoglobin level, blood oxygen saturation, and cardiac output, but inversely proportional to body oxygen consumption, which is mainly determined by basal metabolic rate or body temperature. Therefore, red cell transfusion is likely required in a patient with decreased blood oxygen saturation or cardiac output, or increased oxygen demand or consumption, such as fever. Furthermore, a higher oxygen carrying capacity is desirable in a patient with coronary artery stenosis. With all things considered, we proposed the West-Channel score and an individualized red cell transfusion strategy to guide the transfusion of the surgical patients. As this table shows, we use adrenaline infusion rate to represent cardiac output, fraction of inspiration oxygen to keep SpO2 not less than 95% to represent pulmonary function, and core body temperature to represent oxygen consumption, and history of China to involve the most sensitive organ, heart. The final score, the initial score is 6, and the final score is 6 plus the sum points aggregated for all 4 items. For example, if a patient does not need adrenaline infusion, we do not need to add these points. If his cardiac output is maintained with small dose, that is, less than 0.05 microgram per kilo per minute, 1 point will be added. And if this dose is more than 0.06, 2 points will be added. So the minimum score is 6, and the final score will be 6, 7, 8, 9, 10, or more than 10. But if the score is calculated more than 10, such as the patient has 2 points added in all 4 items, and his score will be 14, we treat the patient as his score is 10. So the maximum score is 10. And it's a dynamic score whenever red cell transfusion is considered. And it should be carried out when the patient volume status is clinically normal as assessed by clinicians. The West-Channel score is proposed to evaluate the red cell transfusion trigger based on each individualized patient status and the patient's instant hemoglobin level, and further to determine the target hemoglobin level on the basis of this evaluation. So it's a score for determining red cell transfusion trigger and target. And how can we match West-Channel score with red cell transfusion trigger and target? Its final score. For example, if a patient has a score of 6, his transfusion trigger is 6 grams per deciliter, and the transfusion target is 6 grams per deciliter at the same time. The score is individualized and real-time. Whenever red cell transfusion is considered, the first step is to evaluate the patient's condition by West-Channel score, and then to measure the patient's hemoglobin level. If the score is less than the instant hemoglobin level, red blood cells transfusion will not be necessary. And if this score is more than the HA level, red cells should be transfused, and the volume of red cells is calculated as the difference of the West-Channel score minus the instant hemoglobin level. So the score is transfusion trigger and target at the same time. Finally, let's make a deeper impression on West-Channel score, the individualized red cell transfusion strategy by revisiting oxygen delivery and consumption. Once again, I want to thank all of you for giving me this chance to present this topic. Thank you very much for your kind attention.